Morning everyone. Today I will be discussing my seminar on the topic TMJ Biomechanics Part 2 in which I will be discussing about functional loading and joint components. In the previous seminar we talked about the anatomy of the TMJ and how biomechanical forces comes to an act. In this functional loading, how the changes will be there in the functional and the parafunctional habits, we will be discussing it. So coming to the definition of functional loading refers to the mechanical stresses that is transmitted to the joint during physiological functions. Either it can be through swallowing, mastication and speaking, or through the parafunctions that can be seen in the bruxism and the clenching habits. We have three types of loads that is coming into the action of biomechanics in TMJ. First is the compressive loading. It is a dominant force that acts during intercuspation and mastication. Second one is the shear loading. It arises during translational movements, specifically during the lateral excursion movements. And the third one is the tensile loading. It is applied to the retrosternal distal tissues and the capsular ligaments of the TMJ during wide opening and protrusion. The magnitude of forces, how much bite forces are there. So the bite forces ranges from 500 to 700 Newton in healthy adults, with higher values in males that can be up to 850 Newtons. During unilateral chewing, when we chew on the one side, peak loads occur at the balancing, that is the non-working condyle area, particularly against the articular eminence. And these forces are directed antero-superiorly in direction, and it is not purely vertical. So the magnitude of forces, how it acts, we have discussed. When we talk about loading, two types of loading are there. Adaptive, that will have during physiological functions, and pathological loading that will be discovered when we have some TMJ pathology. So how the TMJ remodels to adaptive remodeling. Under normal functional loading, the TMJ adapts to fibrocartilaginous proliferation, enhanced collagen fiber cross-linking, and bony acquisition at the condylar and the articular eminence to better withstand the future stresses. When there is a pathological overloading in cases of TMJ dysfunction, excessive or the abnormal forces exceed the adaptive capacity, leading to disc deformation or perforation. Condylar resorption can be seen, and degenerative joint diseases and clinical TMD manifestations can be clearly seen. How the load tolerance takes place? So it is a biomechanically designed joint to resist short, intermittent dynamic loads for chewing habits, that is the functional habits. But it is vulnerable to sustained static forces like prolonged clenching or bruxism, which can accelerate the tissue breakdown. So this is about the functional and the adaptive loading. When we come about through the joint components in the load distribution, how the various joint components play a role. First comes the condyle. The condyle is covered by the fibrocartilage and not the hyaline cartilage like the most synovial joints. So the superior surface is designed to withstand compressive loading forces and resist the shearing forces. Remodeling in the condyle is through the endochondral ossification in response to altered mechanical environment. When we talk about the articular disc and its role, it is covered by the biconcave fibrocartilage. It has three zones: anterior band, intermediate zone, and the posterior band. These bands function to redistribute the stress across the condyle fossa interface, enhances joint congruity, and protects the osseous surface from peak point loading. When there is a disc displacement, it will be a cause of abnormal load concentration in which the retrodiscal tissue is under stress, excessive stress. So when we come to the role of glenoid fossa and articular eminence, the glenoid fossa is a thin fossa bone. It is poorly designed for direct load bearing. Articular eminence is the main load bearing area. So the slope of the eminence determines condylar paths and alters either it will take shear or compressive loading ratios. And when we talk about the retrodiscal tissue, It is highly vascular in nature, elastic connective tissue, and because of this vascularity and elasticity, it will absorb tensile loading during forward translational and while opening. It is susceptible to painful overload in this displacement without reduction. So when we treat the disc displacement without reduction, we have to see about the vascularity and elastic connectivity tissue recoverage. Coming to the ligaments, we have the collateral ligaments that will anchor the disc to the condyle, ensuring the disc condyle unit is properly maintained, and the capsular ligament defines the joint space, limits excessive movement. And specifically, the temporomandibular ligament resists excessive posterior and inferior displacement, preventing condylar intrusion into the external auditory canal. Now coming to the clinical relevance. What are the clinical relevance of these biomechanical forces in various TMD conditions? So firstly, coming to the temporomandibular joint disorders, specifically in chronic parafunction, that is seen in cases of bruxism and clenching. It produces sustained static compressive overload which compromises the synovial fluid exchange and disc nutrition, leading to ischemia in the place and fibrocartilage thinning and eventually degenerative arthritis of the TMJ. When there is disc displacement, it increases the tensile loading on the retrodiscal tissues, stretching the bilaminar zone, causing a vascular congestion in that case. Inflammation will be there, pain on function will be there, chronic displacement without reduction can further alter the condylar loading patterns. When we talk about prosthodontics and restorative dentistry, the changes in the occlusion, the vertical dimension, directly modify the spatio-temporal relationship of the condyle with the fossa, thereby shifting the direction and the magnitude of the vectors across the point. Excessive increase in the OPD can overload retrodiscal tissues. When we talk about balanced occlusion schemes, incomplete denture prosthodontics, careful occlusal equilibration should be done in restorative one that will distribute forces more evenly, that predisposes to TMD if they are not done properly, and it will lead to accelerated wear. When we talk in orthodontics and orthognathic surgery, specifically the mandibular movements and the mandibular repositioning via the orthodontic devices and the orthognathic surgery alters the condyle fossa relationship, subjecting joint components to new loading patterns. The condyle may undergo adaptive remodeling through endochondral ossification, as I already told, and fibrocartilaginous thickening to accommodate the new position, especially in the growing patients, that is the pediatric populations and the adult group populations. But in some patients, specifically in the post-pubertal females, it is seen that these altered forces may trigger the pathological relationship of the condyle, leading to the relapse of the surgical correction or open wide deformities. It was done through a study. Now coming to the last thing is that the conclusion, the TMJ is a highly specialized load-bearing joint optimized for intermittent functional forces. Components that is a disc, condyle, fossa, tissues and the ligaments work as a biomechanical system to absorb and distribute the loads evenly. Pathological or sustained loading overruns the adaptive capacity, leading to various TMD manifestations. Clinical implications correlating with the surgical backgrounds in prosthodontics, orthodontics and oral surgery can further enhance the management and provide personalized therapy.